streaming on YouTube. And I'll say, welcome to Medical Mondays with Dr. O. Streaming on YouTube. Strong Girls, Strong Future. Good evening. I'm Tony Okwesomi, a physician, family practitioner, HIV specialist, and I treat addictions in Maryland across a few of our counties and the city of Baltimore. So again, welcome to Medical Mondays with Dr. O, where we share medical information to get us healthier. Tonight, we have one of our very own again, it's always our very own, Dr. Camellus Ezeugwu, who has over 25 years experience in internal medicine and is also an interventional cardiologist and critical care specialist. He has his own private practice, Just Heart Cardiovascular Group in Baltimore City. He also is an assistant professor of medicine at the Johns Hopkins University School of Medicine in Baltimore. Dr. Ezeugwu does not only do amazing things when it comes to heart and heart health in Maryland, he actually works internationally. And I'm going to have the opportunity tonight to tell you more about the cutting edge medicine he has taken to Nigeria. So without much ado, Dr. Ezeugwu, the floor is yours to tell us about how hypertension can destroy the heart and what we need to do to prevent it. Thank you.
Thank you, Dr. O. Thank you for the wonderful introduction. And thank you for this forum, which has really been extremely very well received and impactful to the life of many of our people and the different topics you bring to bear here. Thanks for the opportunity to come and talk about hypertension, which you guys know is a big issue for us. But I'm going to be focusing the discussion on hypertension with reference to heart and heart failure. So I'm going to share my screen. Okay. Can you guys see my screen?
Yes, we do.
Okay.
Yes, you can do slideshow.
Yes, we're gonna get to that in just a second. Okay.
There you go.
Alrighty. Give me just a second. I might have a little. Okay. Let me see and get this out of the way. Okay. All right. Today we'll be talking about hypertension for heart failure prevention, 2022 best practice. I'm gonna stop sharing for some reason because in this mic from my end here, this is not showing up right. Just give me a second, please.
Okay.
Mm.
It looked beautiful to us.
Yeah. Okay. I think this looks a little bit better for me. Able to see now?
Yes.
Yeah, I was
Okay.
just
Okay, very good. Well, I have nothing to really disclose, relevant disclosure on this particular topic. Yes. Okay, good. Well, 2022 brought us with a couple of things about heart failure. Among them are new guidelines and new definitions. But basically, the bottom line, of what we're going to talk about today with heart failure is that you have to know if you're at risk, and that early detection is very vital. And preventing heart failure progression is key. And when heart failure improves, when the heart function improves, we should not stop the therapy and always work with the doctor to really, get that done. Okay. Our goals today will be one, to define hypertension. Again, talk about early detection. And then define what heart failure is and who is at risk. and how does it happen and progress, and how is it treated? And then you answer again if you're at risk, and then if it can be prevented, and what can you do, or I do. Let's start with a question. Question one, this is not a question and answer thing, but just to bring home some issues. A healthy postmenopausal 53-year-old woman presents for evaluation of elevated blood pressure. At her most recent primary care visit, her blood pressure was 138/88. At the time of presentation, her blood pressure is 132/80. The patient wants to know if she has hypertension. So which of the following best describe her blood pressure? Is it A, stage 2 hypertension is present? Pre-hypertension is present. There are inadequate blood pressure readings for a diagnosis. Blood pressure is normal for her age. Or is it stage 1 hypertension is present? So think carefully about this. If you answer that stage 1 hypertension is present, you'll be correct. Now, so what are the stages of high blood pressure? Well, normal blood pressure we consider if systolic pressure is less than 120, and if diastolic, which is the bottom number, is less than 80. We consider elevated blood pressure if the systolic, which is the top number, is between 120 to 129, or the diastolic, again, less than 80. But once you start going upside this, you have stage 1 hypertension, where the systolic, the top number, is between 130 to 139, or the diastolic between 80 to 89. In our patient, again, you see what the diastolic is on this patient, okay? And then it can be stage 2 if the systolic is at least 140, or the diastolic about at least 90. Now, when you have a disparity between the two, whichever one is higher, whether it's the diastolic is higher or the systolic is higher, that will push you into what stage the patient will be at. Now, we in medicine, our primary goal usually is really to make a patient better and to manage disease. And in managing disease, our goals are, one, to prevent that disease, treat the disease if it's present, improve the quality of life of the individual, and prolong life. If you take that then to here, when we then look at classes of hypertension, this is not stage now, you will find that we have those patients who consider normotensive, they have normal blood pressure. They are not on medication, or they are on medication and the blood pressure is controlled. So we call those as being normal. And this, let's look at the, in the office. You check a patient in the office and those numbers are good. Again, whether they're on treatment or not on treatment. Then you have some of them, when they come to your office, their pressure is high. And in the doctor's office, so we call them white coat hypertension. Now, you may also have them that they have blood pressure being treated, but then when they come to the office, their pressure is high. They're called white coat hypertension on treatment, but that pressure is high. Again, that's defined by those numbers. Then you have some individuals, when they come to your office, it's actually a relaxation thing for them and their pressure is good. But then when they're at home, their pressure is high for whatever the reason is. And those are masked hypertension. Now, some of them may be hypertensive patients that you have on treatment, but they are actually at home, their pressure is really high. And this is why we usually do home blood pressure monitoring to help pick those patients up, those who have that masked hypertension. And then you have those who their pressure is high regardless at all time, whether they're on treatment or not, their pressure is way high. Now, the key thing to pick up on this class thing is that if you look at the complication rate, let's say for end-stage renal failure, this is really dependent on the stage, on the number. So if, previous people would think that white coat hypertension is inconsequential. No, it has a consequence, cardiovascular consequence, and renal consequence. Because again, every time those pressures are going up, the end organs are failing. So you see that depending on what stage you are, it doesn't really matter the class. your pressure do affect those organs, badly. So what must we know about hypertension? The burden is key. The hypertension develops very early and more common and severe in the Black compared to the white patients. So some of people even in teenage age, with blood pressure issue, we need to be able to know how to begin to pick this up. And people that even have, where a mom had preeclampsia, which would then predispose the child even to have blood pressure. We have to be aware of this. Black patients are likely to have controlled blood pressure and at greater risk of developing hypertensive complications compared to white patients. The worse the hypertension, of course, the stage, the worse the kidney dysfunction. Over 60% of Black patients with heart failure have antecedent history of hypertension. Again, underscoring the hypertension, role in heart failure, and this is why we are combining this discussion, focusing on this, as a putative cause of left ventricular dysfunction. Whereas 30% has coronary disease as the suspected cause of LV dysfunction. Once affected with heart failure, the natural history of the disease becomes worrisome. And this is why we're really looking at how we can take care of this sooner and earlier. So now let's move into discussion about heart failure. What is it? Well, when a heart cannot function efficiently to meet the body's demand, then we're considering that heart as failing heart. Now, this problem of the heart can be because the heart has issue with pumping, or the heart has issue with relaxation. As you guys know, the heart can pump or relax. Now, this goes gradually, goes from failure to failure. And again, it can happen with either of these. And then when the patient gets congested, that's when all of us begin to know that the patient has heart failure. Now, this issue can happen because of structural problem, or function of the heart. If we take this as a normal heart and look at this wall of the heart as normal thickening, if something happens to the muscle of the heart where it thins out, like this is thinned out here, and it cannot pump well, then when it pumps, it doesn't pump out very much. And that's where the pumping of the heart is lower. We call it heart failure, which reduced ejection fraction. So you're gonna be hearing things about HEF, REF, and then HEF, PEF. Now, if you have a situation where the wall is thickened, like you see here, where the heart has no issue with pumping, it pumps out blood easily, but it doesn't relax very well because of the muscle thickening, which tend to happen also with blood pressure. But you get what we call heart failure with preserved ejection fraction. Okay. Now, when those things are happening, now you may start having a patient where the patient now is having issue with breathing, or feeling tired, or they cannot exercise very much, or they have fluid retention, or their lungs are being congested and they're getting, swelling in the legs. That is when the functional issue becomes a problem. Now, this functional issue can happen even when the pumping of the heart is normal, but it cannot relax, which is heart failure or preserved ejection fraction, or when the pumping of the heart is now weak because the muscle is thinned, called heart failure with reduced ejection fraction. So heart failure is described in different formats of this. Now, as we mentioned earlier, this starts gradually. Something happens to the heart, and gradually it can affect the pumping or the relaxing, and then it goes to failure, and then congested. When it gets here now, all of us know, because the patient will come and present and tell the doctor they can't breathe, or family or whatever, that again, this can be stopped earlier. We also can define heart failure by actually defining how much blood the heart pumps out when you have the heart filled out with blood and it squeezes and pumps out blood. If it pops out less than 40%, we refer to that again as heart failure with reduced ejection fraction. But if it pumps out more than 50%, we refer that as heart failure of preserved ejection fraction. That's again when the patient is already having symptoms. You can use this to define those conditions. Okay. In 2022, more definitions of heart failure came into play. Where again, if the pumping is less than 40%, we refer it as heart failure with reduced ejection fraction. And then if it's over 50%, we call it heart failure with preserved ejection fraction. But then there's what we call now a mid-range, where the pumping is between 41 to 49%. Why is this important? Well, it's important to understand that the heart can actually begin to fail, where the pumping may go from being good to get all the way to being bad. And you can actually do a treatment where you can actually improve the pumping of the heart. So somebody in the mid-range can go this way or go that way. And when you do improve that, not to stop medication just because there's improvement, because the underlying cause is still there. Okay. So what are the crucial concerns we have with heart failure? Well, the thing is to know that the incidence of heart failure is high and it is increasing. Readmission is an issue with heart failure, and it costs a lot with morbidity and mortality. The burden of hospitalization is increasing, and Blacks are at higher risk. Okay? And heart failure is deadly and costly. And most of that cost being the burden of hospital admissions. If we take a look at this graph projected by ethnicity in terms of heart failure incidence, this is from 2012 to 2030. If we take a look at this green line here, yeah, that represents Black. So they are leading in this heart failure thing, okay? And this is important because we all see, that a lot, and we see a lot of Black patients, and it's important for us to know and also begin to know what is the primary cause for that and see how we can begin to manage to really make a change in this here. Okay. If we look at this in terms of mortality projected from 1999 to 2017, look at among young adults, 35 to 64. And again, older adults, 65 to 84. Among the young adults, look at this blue line again, representing Blacks, even in the young. And then in the adults, the same Blacks as well. The Black women are here, in the red, following here. In the young, and also in the older, they are here, just behind the white men. Okay, so heart failure is really a major problem in our community, and we have to learn how to deal with it and how best to manage it. Okay, so how does it happen? Well, it happens in stages, okay, from stage A to B, C, and D. We will go over these stages and, relate that and see how we can, again, manage them. So what is stage A? Well, stage A is when patients are at risk of heart failure. And, there has not been any problem, no structural issue with the heart, but the risks are there. We're going to go what those risks are. Stage B is when they have now begin to develop problem with the structure of the heart, but they have no symptoms. They don't know. It's very silent. It's usually when you say someone died suddenly, they don't know, there's nothing happening, but already something was happening, just that they didn't know. They don't have any symptoms about it. Stage C is when they have that structural problem now affecting, but now they are having symptoms, so they begin to find out. So you find that many people are found out at this stage, which is really tail end towards stage. And stage D is actually refractory heart failure, where then a patient is actually waiting for things like heart transplantation in hospice and stuff like that. In Nigeria, of course, we know people end up to stage C because transplantation and all that may not be available. You can travel overseas to get those kind of care. So many of the things we try to do in Nigeria to really see how we can prevent this from getting to that stage. Okay, so who is in stage A? Well, literally anybody with a heart is in stage A. I'm sure among us here, we know people that have high blood pressure. It's a major risk. People are diabetic. people who have any vascular problem like lupus, or family history of cardiomyopathy, or alcohol issue, or obesity, or excess stress, or even born with congenital heart problem, or sleep apnea, or thyroid issue, cancer, or chemotherapy, or cholesterol, or even irregular rhythm of any sort, amyloid, many other conditions that can, lead to heart failure. When you have any of these risks, you are in stage A, and really identifying those patients are very important. Now, when it comes to heart failure in the African, etiology of heart failure in African Americans, you find that high blood pressure is a major cause here. Okay, that high blood pressure leads to LVH and is a major cause of heart failure in the blacks. Okay, and again, that's why we're emphasizing hypertension management to really prevent heart failure in these individuals. Coronary artery disease, on the other hand, is a major cause for heart failure in the white population. Now, of course, there are some black patients that will have coronary disease and high blood pressure, or vice versa. But purely speaking, as a major cause, this is what we have here, and trying to manage them becomes important. So, lesson number one in preventing heart failure, especially blood pressure issues, to identify and manage risk factors like hypertension early and effectively. If we begin to pick up our hypertensive patients early and manage them, we will be impacting the incidence of heart failure and the morbidity of mortality of heart failure in our community. So then we move to stage B. As we mentioned, stage B is when there's structural issue that it is silent. The patient don't know. Okay, and these things can kill people at that stage. So again, stage A here, we have the risks. Now we're now in stage B. They have structural disorder of the heart, but they have no symptoms. They walk around without knowing there's any problem. They can do whatever they are doing and have no issue. They don't even know that. And all of a sudden something happens and the person dies. And then like, what happened? It was very good, doing very well. Okay, because the risk was never assessed to see what's going on with the heart during that time. Okay, so the most important thing here is that you have to really search for it to find it. If you don't, you're gonna miss it, and then they're gonna progress into stage C. If they're lucky, if they don't die in this stage, they progress into here. And as we mentioned, most people, like in Nigerian situation, end up here. If they don't die here, they end up here. This last end stage of transplantation, or LVAD and stuff like that for the support, we don't have that we really don't have that. Okay, so lesson number two in this situation is to know that absence of symptom is not absence of disease. So we really need to look for that to find out, not just because they don't have any symptoms. Okay, so how do they move from stage A, through the other stages? Well, it starts from initial damage or injury caused by an unmanaged risk factor, such as high blood pressure. Once that happens, you have what we call activation of neurohumoral mediators. And then you have disease progression from that, because these mediators will lead to that progression, and then symptom development, and then, of course, increased morbidity and mortality. So let's take this heart, for instance, and say there's a damage to this heart, whether it is because of blood pressure, you didn't pick it up in time, it's beginning to brew when they're a child or they're teenage or whatever. What the body does is there is a pathophysiologic response, which actually this response can be damaging to the body. But then the heart also tries to use what we call neuropeptide pathway to try to fix things so that things will remain balanced. If the damaging part gets worse, and this yin yang is worse here, then the heart begins to fail. As this one goes, if the disc is dominant on this arm, the heart begins to fail more and more. If this can repair it, you can be in a balance. Now, I want you to just keep in mind this thing called RAS system. Okay, we're gonna talk about it, there are many things that goes in this RAS system. Just, simplify, just remember this RAS system that cause most of the damage. And there are pathways that goes to form this, what we call angiotensin 2. We're going to talk about this angiotensin 2 a lot. And of course, this angiotensin 2 will go into what is called its receptor, which is the AT1 receptor. And then once it gets there, it causes all this to happen, increasing blood pressure, increased sympathetic tone, aldosterone production, increased sodium fibrosis, and more damage. Again, keep in mind this aldosterone here, and angiotensin 2. The body will try to repair this, and natriuretic peptides can come from different areas to try to fix, the body here. And their goal is to try to counteract the effect of what the RAS system is doing by improving blood pressure, decreasing sympathetic tone, reducing aldosterone, natriuresis and diuresis, and, anti-fibrotic effects. So again, these two systems try to fight each other. Okay. It should be very important to know, as we pointed out, angiotensin 2 is the main effector molecule of RAS, this angiotensin 2, as we pointed out in here. And of course, that effect does not happen until it hits that AT1 receptor, until it hits this receptor. Okay. It causes increase in blood pressure, influences renal tubule to retain sodium and water, and stimulates aldosterone release from adrenal gland. So angiotensin 2 and aldosterone are major culprits in these pathological things that happen and leads to further failure of the heart. Okay. So hypertension is, again, the RAS system and role of angiotensin 2 and aldosterone. Again, it all starts from, there are many pathways to this that are bringing you down to here and here, okay? But remember, it starts from renin, okay? We have increase in this, will lead to aldosterone, angiotensin 2, and then aldosterone release, okay? Now, we're gonna focus on this because again, this is the common, final pathways that lead to most of the damages, okay? But anything that stimulates this to increase will lead to more of these, okay? So what medications and the effect on renal? As we mentioned, anything that leads to more of this will lead to, more of this and more of that, okay? So among the medication that will increase renal activities include diuretics, calcium channel blocker, the dihydrogenase, hydralazine, and medication that would decrease the plasma renal activities, of course, it blocks them, are the ACE inhibitors, and also angiotensin receptor blockers and some beta blockers because of the receptor on the adrenals. Okay. Again, just to emphasize that it all starts from renin. Okay, just follow you start from renin, and again, many pathways producing angiotensin 2. Now, if angiotensin 2 exists, it will cause a lot of widespread vasoconstriction, blood pressure, and all that, of course, through aldosterone in the tissues. Okay. But final common pathway, the adrenals will also release aldosterone. And when aldosterone is released, the question becomes, what happens to those tissues? Okay. So I hope you can still see this. Okay. Aldosterone is it's present, this receptor is present in many tissues. It will lead to, myocardial fibrosis. It also leads to vascular injury and fibrosis in the vascular system, decreased vascular compliance, impaired baroreceptor function, causes endothelial dysfunction, catecholamine release, heart rate variability decrease, ventricular arrhythmia, progressive renal failure, potassium and magnesium loss, sodium reabsorption and water retention, and prothrombotic effect on the PI1. Now, of course, these will affect these organs: end organ renal failure, end-stage renal disease, ischemia to many parts with small vessels, strokes, heart failure with LVH, and of course, worsening hypertension. So this particular aldosterone is a major problem in tissue problems. Okay. Now, is it only aldosterone coming from the renal area? No. Aldosterone can come from even fat tissue. And that will explain some of the blood pressure issues we see, in obese patients and stuff like that. And of course, the cardiovascular effect of that. Okay. And so understanding the different source of it is very important. And again, emphasizing, the fat cells can actually release aldosterone itself as well. There's many times we try to make sure we can not only treat where those sources are and to reduce complications. And you can find an obese patient who may just have heart failure just from obesity, and it has to do with this particular thing we're just discussing about. So screening for heart failure in those patients are very important. Now, okay, again, talking about the RAS system, we're starting again with angiotensin 2, again, through the different pathways. There are ways we can block them. And of course, the angiotensin 2 here, producing aldosterone. And once aldosterone hits the mineral receptors, its effects in this brain, kidney, muscles, blood vessel, heart, pancreas is a problem and can lead to more damage. And so many times, we try to see if we can block it from getting to those receptors. And also we try to block angiotensin 2 from getting to its receptors. Because if we can block that, then we can spare the life of these organs. Now, what is interesting about angiotensin 2 is that, of course, it causes vasoconstriction, but it can do that when it hits the AT1 receptor. When it hits the AT1 receptor, it can cause this vasoconstriction, proliferation, inflammation, and sympathetic nervous activation, which again are very harmful. But if you block it from hitting this AT1 receptor, the excess of it can go to AT2 receptor. And in the AT2 receptor is actually very good. It can actually lead to vasodilation, anti-proliferative natural cell, tissue regeneration. So by itself, it's not really bad. It's just that if we let it hit here, that's when it's a problem. But if we block that and let it go this way, we can actually have much benefit on it, especially in the younger people and as well. So to keep that in mind, right? So lesson number 3. Target organ damage is a superior predictor of cardiovascular risk to traditional risk factors. And reversal of target organ damage provides an important surrogate endpoint in evaluating treatment. So for us, really, our goal is to prevent those end organs from damaging, and whatever we can do to prevent them is very important. So in dealing with high blood pressure, preventing those organs from damage is important, while you do other medications to try to reduce the number, because the most important thing is really to reverse, or prevent the end organ damage. As I said, those are, those receptors and blocking them. So let's move on with the second question about treating to prevent complication. And I'll read this question number 2. A 60-year-old African-American man presents to clinic to discuss cardiovascular risk. He has no significant past medical history and does not take any medications. He exercises regularly and is a lifelong non-smoker. He tries to minimize salt intake and eats a balanced diet. He denies any exertional chest discomfort or shortness of breath. On examination, the average of 2 blood pressure readings is 136/84. His blood pressure was 133/85 at his primary care visit 2 months ago. His body mass index is 23. The remainder of his examination is normal. Laboratory tests revealed total cholesterol of 220 and high density lipoprotein of 38. Renal function is normal. A urine analysis shows no evidence of proteinuria. His calculated 10-year atherosclerotic cardiovascular risk score is 10.1%. And the question is, which of the following medication would you recommend in this patient? Now, you may find that within yourself, you may be saying, oh, this patient doesn't need medication. Why do I need to treat this patient? But the question is, telling you that you need to treat this patient. Okay. In addition to the risk factor modification that the patient can be doing, which they are doing already, exercise, they are doing everything. It is asking you, which of this would you do? And the reason why is telling you about treating this patient now is that the patient, ASCVD risk is now 10.1%. And I'm sure we have, there was a presentation here about ASCVD risk calculation that people should have that formula to have that and be able to make those calculations. But, it's asking you what treatment would you do? Okay. Now, as many of you, even in the exams that they've set up for, in books before, of course, they will tell you, start the patient on diuretic, which people would choose and do this. But as you know, we talked about what happens in the renal system and what diuretics do and what it does to those organs. So you have to begin to think carefully about this type of management and how best to approach the patient with end organ protection. Yeah. All right. So then let's move on to stage C. And again, in stage C, the patient now have symptoms, okay? Usually they're now congested. Of course, you can diurese them and their congestion go away and they start, not having shortness of breath anymore. However, once you hit stage C, you are in stage C. You don't go back in stages. You are just moving forward this way. So once they have one time of symptom relative to that fluid overload of some sort, yes, they're now in stage C. And they, even when you improve their function and everything, it's also that they go back. Because the thing is that once they are here, the needed treatment is there. If you stop any of that, they would go to D. Okay, so usually, you don't go back in stage D. You can change classes, but not the stages. All right. So again, we have discussed this again, the different stages A, B, C, and D, where you have the risk, you have structural problem with no symptoms, and now here you have symptoms. But the key thing is to know that in the symptom stage, it can happen with heart failure or preserved ejection fraction, or it can happen with heart failure or reduced ejection fraction. And these stages are, really bad, whether your heart ejection fraction is good, or not. And again, of course, stage D is refractory time. Now, what we need to pay attention to is in this distribution study of the stages of heart failure. And look at stage B, for instance. You look in this distribution, as stage B patients make about 59.1%. And again, remember, they are usually very silent. And so you may find people walking around that have on stage B and don't even know it. Okay. Now, if you look at mortality, sorry, this is covering some of this. If you look at the mortality on patients that have heart failure with preserved ejection fraction and those that heart failure with reduced ejection fraction, 5-year mortality in them is the same, superimposed on each other. So you find that these conditions have to be managed, need to be picked up early and manage them to reduce that risk of mortality. If you take a look at this very recent study, actually by Young, this was actually this year. They took about 393 patients between 1997 and 2000, and then within a period of less than 2 to 3 years, you find that some of them, about 199, already developing preclinical heart failure symptoms, heart failure. And when they assess that 66% of them are in stage B. So it's that stage B is a large number of people. And again, it's a very silent stage. Then that's when you have like these sudden deaths we have and like, whoa, how did they happen? It's because nobody screened the patient who is at risk or just waiting for when they have symptoms. Okay. Again, emphasizing that early, heart failure prevention, early detection is the key. If for stage A, excellent history and identifying risk factors is important. And for stage B, we have to assess the structure with testing, either by echo or other type of lab tests. The echo is very good in picking up the function and also looking for diastolic dysfunction on patients. Okay, and it's non-invasive. So lesson number 4. Evaluate, detect, and manage early. Do not wait till symptoms. Okay. So that's one there. Now, if you look at this in terms of, sorry, some of these slide is not showing this. Sorry about that. This is more to do actually with picking up heart failure, and it says to you to wait till the patients develop symptoms, and then you can do testing. As we are showing you, if you are waiting for them to develop symptoms before you do it, you're gonna miss many of them. And so again, is to do the test and pick them up a little bit earlier than before they have symptoms. All right, so what is the goal in managing these patients? One is manage risk factors early. Two is to block adverse humoral activities, the RAS, as we have mentioned. And then prevent end organ damage, again, by blocking aldosterone and prevent left ventricular function deterioration. And reduce mortality and morbidity when you do those things, and then improve symptoms and quality of life. So how do we treat? Well, this is an older slide, and you're gonna see in stage A, they're gonna talk about risk factor modification, family history education, and stuff like that. And then in stage B again, treating use of ACE inhibitor, ARBs, and beta blockers. And in stage C, the same treatment, of course, with again risk factor modification. But you find that when they get to stage D, because again, as this gets worse and worse, the cost just goes higher and higher. By this time, you're looking at hospital-bound patients for LVAD and heart transplantation or hospice. Again, many of our folks in Nigeria don't get to here. And this is why we really have to hammer, early detection and management very much here. When you do it here, it's cheaper, it saves more life, and the quality of life of patients are much, much better than you will wait till the end here. So we have gone through this again, the risks where you go stage A, B, C, and D. Again, as you progress, the cost just goes high, morbidity goes high, mortality goes high. And this is a problem. So medication that have been shown to actually improve, life or reduce mortality include ACE inhibitors and ARBs, beta blockers, mineralocorticoid antagonists, and of course, cardiac resynchronization, and also defibrillators that you guys may be aware of. Okay. So lesson number 5 is to manage the pathophysiology, which means to block the harmful pathways. And this is really so important in preventing, progression and deterioration of heart function in patients with blood pressure or any other risk. Okay. So what are the newer therapies? The newer therapies are designed, again, to block the RAS. Okay. The RAS system, as we mentioned, creates a problem. And again, the AT1 receptor blocking where the angiotensin 2 hits is very important. And of course, you have sympathetic nervous system, which also is important here, and that's why the beta blockers, comes into play. And of course, you have the neuropeptides, which help to repair the body. We try to block anything from damaging them so they can repair the body. And you're gonna find that medications that block these systems will prolong life because again, they prevent us under that damage. But medication that doesn't do this, doesn't block any of this, doesn't prolong life. For instance, you can take clonidine, for instance, to bring your blood pressure down, or Procardia to bring your blood pressure down. But it does not have mortality advantage or mortality benefit when you compare that to something like an ARB, or a beta blocker. And you can, as you see in those situations, even though they will bring pressure down. Okay. So let's spend a little bit of time and talk about these neuropeptide pathways. So the body have what we call atrial natriuretic peptide, which again is a neuropeptide that comes from the atrium for repair of atrium. You have B-type natriuretic peptides, which also come from the ventricle, but you also have the C-type natriuretic peptide that come from the vessels. So these are really designed to repair. And of course, you have blood vessels everywhere in the body. Okay. So when things are happening, they are helping to repair those vessels in different areas. However, there's also neprilysin that can actually destroy this, and if these are destroyed, the body product, those of you in oncology know that some of these neprilysin, you can see them in oncology levels and stuff like that, they're higher. But as they destroy these, then these organs are left for destruction. So in trying to protect these organs, not only do we have to deal with the RAS system blocking them, we also have to block the effect of neprilysin from destroying these neuropeptides that helps to fix this organ, the tissues. Okay, so newer therapies. Let's go back in again here. We talked about the damage and the RAS system. The newer therapies, our goal is one, the RAS system angiotensin. Two is to block it from hitting the AT1 receptor. And also we talk about things that will prevent neuropeptides from being damaged so they can repair the body. Because if this continues on this pathway, you have more damage and more destruction and more heart failure. So we have newer therapies on what we call ARNIs, okay, which is angiotensin receptor neprilysin inhibitor. They're like a combination of medication that block this pathway, the RAS system, but also block any neprilysin that will destroy the neuropeptides so that they can be free to fix the body. So when we start beginning to manage some of these patients, our goal is to block those effects. So once you block them to protect those organs, then you can use other medications to really try to bring the pressure down. So again, looking at the ARNIs again, a typical example which was studied is the sacubitril valsartan, which we call Entresto. The valsartan, it will block the AT1, where angiotensin 2 goes. It will block it right there. And as we mentioned, when you block AT1, then the excess angiotensin will go to AT2, where it actually is beneficial. So you direct it to really do good work rather than doing bad work when it goes to AT1 receptor. Okay. And the sacubitril, of course, will prevent neprilysin from really, destroying the peptides, so that by not destroying the peptides, then you can preserve that, protection of the body through this. One thing to keep in mind is that when we use ACE inhibitor patients and they are labeled as being allergic to an ACE inhibitor, the system will make it difficult for you to give them any ARB. And when they don't get an ARB and they don't get any ACE inhibitor, their organs are left open for complete destruction. So it becomes important to be very careful then before giving people ACE inhibitor who may be allergic to them, because they will benefit a lot more with an ARB that will be more direct into those receptors and protect them. To keep that in mind. Again, re-emphasizing valsartan sacubitril, the valsartan part of it, again, an ARB block the RAS system, preventing destruction, and the sacubitril prevent neprilysin from, destroying the neuropeptides so that then the body can be repairing itself. So newer therapies, again, for heart failure include what we call the SGLT2 inhibitors. Why are these important? Well, they are originally even for diabetes, but they are very good for heart, and they there's reduction in cardiovascular death and hospitalization for heart failure. And this is independent of whether they have type 2 diabetes or not. And they are additive to ARNI, as we mentioned, and other goal-directed, this thing. And you have is beneficial in both heart failure or preserved ejection fraction and heart failure or reduced ejection fraction, and even in patients that have kidney problems. Okay. So we're going to be finishing very shortly and then going to questions. You have the SGLT2s again, very, very important in improving kidney and heart failure. So those are very important to know. But lastly here is that approach to preventing heart failure in patients with hypertension. These are the cardinal things. We have the ARNIs, the beta blockers, we have the SGLT2 inhibitors, and then the mineralocorticoid receptor blocking agents that we carry today. And then we have other add-ons to cardiac this thing, which include cardiac rehab for the patient with heart failure or heart failure clinic. And of course, remote patient monitoring, which we use to pick up these conditions early and really begin to manage them and treat them. And we will stop here and go for questions and answers. We'll discuss anything else that might come up. Okay.
Thank you so much. Even though with the questions and answers, we will see, how much our audience got from that. That was deep. Thank you for educating us on, high blood pressure and, heart failure. It's very important to prevent. So if there's anything, I think, take away from here so far, catching it early, working towards prevention, like we always say, is the best thing to do. But I want to ask a question first before I go to the people in the chat box. And Dr. Aluya is staying put to, add some into this conversation. So you mentioned white coat hypertension. Before, I know when I was in medical school, we thought it was a small percentage of people that have high coat hypertension, meaning when they get into a clinical setting or a hospital, their blood pressures go up. Whereas outside of those settings, the blood pressures are normal. We've now seen that that is not true, that more people actually have what we term high coat hypertension than we think. But so we ask people now to monitor their blood pressures at home, because if blood pressure is normal at home and it's only elevated in the clinic, and we check their blood pressure measuring device, sphygmomanometer, we check it with ours to make sure that it's good. It's about the same. So what they're measuring at home is accurate. Then we conclude that they don't have high blood pressure. That is white coat hypertension. But you said some things that, I think we need to, elaborate on some. One, you said even those blood pressure spikes are not beneficial. They can still destroy the heart. One. Secondly, you also said there is a population of patients who their blood pressures may actually be okay or about okay in the clinic, but it's elevated constantly at home. That's the reverse. Can you shed more light into that for us?
Sure. Excuse me. So again, the blood pressure as a number is just telling us there is smoke, or there's fire somewhere. Just like you look at the house and there's smoke coming up, you say there's a fire. But remember, there's fire that can be burning very badly, and there is really no smoke. And the end organs, by pathophysiology, the small organ, the small small vessels that go to them, really see those hits all the time. So when you look at cardiovascular risk or renal risk, it doesn't say if you are in class, where you are normotensive all the time, or that your pressure is up in the office only, then your kidney is spared. No. If your number is hitting that high, you see that risk is there, okay? And of course, masked hypertension is very important to pick up, because some people, they are at home for whatever the reason is, stress at home, whatever, not sleeping, whatever the reason may be, pressure is high. So their organs are exposed during that time. So we really monitor, and when you monitor and pick and begin to treat, you manage them continuously. It's not like you manage them and then you say stop. Some of them you're gonna begin to pick up that it maybe depends on what they eat at home at that time, and you begin to really correct that. So it's a major problem that, so those classes and those, where we're told is white coat hypertension, don't worry about it. It's not true. Now, those patients that you mentioned those things in, what you could do is also check their urine for albumin creatinine ratio, get an echo on them, and begin to see if they have any end organ damage already manifested. And of course, and then begin to manage them that time. Yes.
Thank you so much. Yeah, that was going to be my next question. That should we start getting echo on all our patients with high blood pressure? I don't know. Should we get a baseline echo like we get baseline EKG?
So that that question is a very important question. And what does an echo cost? Probably, I don't know, less than $300. And if it's picked up early and the patient is managed properly, you're gonna find that the incidence of heart failure goes down and the cost of care down the line is much lower. So if you are seeing a patient who is now has high blood pressure with you now is 2 years, 3 years, it would be reasonable to really assess the risk on that patient. Just the same way you would have done albumin creatinine ratio. There's nothing wrong with checking, but not just check and look and they say, oh, LV function is normal. LV function may be normal, but does the patient have diastolic dysfunction? Do they have issue with the relaxing of the heart? Does the report give information on the relaxing of the heart and the pumping of the heart? Because if they have issue with the relaxing, they have the same risk as those that have issue with pumping. And understanding those two to manage them is very important.
Thank you. Thank you. In case anybody does not know, LV is the left ventricle.
Left ventricle.
That is where the heart pumps out the blood, right there in the left ventricle. And that's the pressure. The pressure there is the pressure we record there is the pressure that is on the top. When you look at your blood pressure, is the pressure with which the heart pumps the blood out. That's the systolic pressure. That's the top number. The bottom number in blood pressure is the pressure with which the heart feels. That's the diastolic pressure. So I'm going to ask one more question before I bring Dr. Aliyah on, and then I ask the questions in the chat box. So you remember the research that came out, it must have been like 2-3 years ago, it's very recent, that for the first time looked at the medications that are best to treat people of different races. You remember that research? Okay, so we know that in the past, researches were done on Caucasian males. And we've now known that Caucasian females, Black males, Black females, Asians, everyone else present differently when it comes to cardiovascular things and maybe many other things. And one of the things that was found in this research a few years ago was that calcium channel blockers, and pardon me, people who are not medical, a type of medication, and the diuretics are the best for Black people. But you are saying here that we should use the ARBs. Yeah, I agree. ACE inhibitors, I'm really very careful because a lot of Black people actually have adverse reactions to that. But you didn't mention calcium channel blockers at all. Again, for the audience, it's a type of medication that they say is the best in Black people. And we see that this everything that was discussed tonight affects Blacks more than any other race. So, and the diuretics, hydrochlorothiazide is not there. And, I agree, clothalidone is my go-to now for years, but please shed a light on that.
Yeah, that's a very, very, very important question. And I really apologize in the reason how I presented this to really look at the receptors and how these things work. I know fully well that our entire audience may not understand it, but I wanted us to bring this knowledge to forbearing because many of us manage these patients and have people that, are in these conditions. And many of us who are here understand pathophysiology very well and the importance of receptors and activities. The research, that you mentioned about in terms of calcium blockers and diuretics, reducing blood pressure and, removing sodium and all that is true. However, bringing the number down is different from saving the organs, okay? Because I said the surrogate of saving the end organs is a much more determinant of not only morbidity and mortality, but also the effectiveness of therapy. So you find that many African American patients, many Black patients, and I struggle with this with fellows, residents, and students, because in the book, they will tell them calcium blocker and diuretic. That's always what they're gonna tell you. I tell them that you're gonna answer in examination question that, okay? But when you're managing these patients, please protect their organs, because if you walk into a dialysis unit, almost 90% of them are gonna be Black patients on that dialysis, okay? And the thing is that we're not protecting the organ. And then we say, oh, they are causing your heart failure. All of them are heart failure. They are leading this path. But the issue is that we're not giving them medicine to protect their organs. We give them an ACE inhibitor, lisinopril, and they swell up, and then we say they're allergic to any blocking medication. And the most classic important medicines that block those organs from being damaged, they are deprived of those medicines. Okay? And now there is nothing wrong with putting those medications to protect the organs, and then use other medicines to bring the pressure number down. Yeah. You can combine them, okay? And in that way, the organ is functioning okay, while you then try to bring the numbers down. I mean, it got to a situation where you can pay almost a penny for lisinopril, and valsartan will be so expensive that people cannot afford it. But now they are changing those things. But that's again. It's important to know you can use those medicines to bring the number down, that protect the organs in the process, please.
Thank you. But, valsartan may be expensive. Losartan is not that expensive. So we still have that to go to too. Thank you so much. And, on this side, I want to welcome Dr. Veronica Obodo Ekblad. She just moved from California over here, and we are excited. I'm excited you're on the forum tonight. And, I'll revert back to you in a bit. Dr. Nelson Aluya, where are you, bro? That's our chair of NAPAC, Nigerian American Political Affairs Committee, that I am chair of the Virginia, DC, Maryland, Delaware, and Pennsylvania of. This is our national president, Dr. Aluya, please.
Well, thank you so much, Dr. O, and I must thank you for doing this, for bringing, the knowledge and information to our community day in, day out, every week. You do this, and you bring such great and very knowledgeable experts as well to talk on key issues that affect our community. And as well as she didn't add to it that she's the chair, the chair of the medical team of NAPAC. So which is so it's in line with exactly what NAPAC stands for. We just don't do politics and policies. We do health, advocacy, and so many other things that we do. NAPAC is the Nigerian American Public Affairs Committee. And some of you must have seen some of the things we did recently with the Nigerians who got, or Nigerian Americans who got elected into office. But, that's another story. But I must thank my very knowledgeable and erudite, colleague who has done such great justice to discussing hypertension and how it affects everybody else, and racial disparities and everything, and the medications and the receptors as well. But I'll take it from a couple of prongs. Hypertension is so big. It's so big and so important, and that we often neglect the big effect that it can have on us as a people. First, as human beings, and as a people, especially as Blacks. One of the things that we begin to really understand is understand us as a people. When I use the word us as a people, meaning people of color, because for the longest time, we have not had people who stand on that platform in our stead, meaning the research that comes up, the statistics that are showing the medications that we take, if they're working or if they're not, the functions of our system, our kidneys, our heart, and everything else. Are they really the same like everybody else? No, they're not. Because now we begin to find people who stand on those platforms and say, you know what, how about us? Let's do our own study. Let's do the things that concerns us so that we will see how these things really function for us. He talked about all this, the stats, what's of us on dialysis, what's of us kidney failure, what's of us heart disease, what's of us, but why is it like that? That's one of the things we have to ask questions. Why? There are reasons for it. You can look at it through anthropology, and you can look at it through a couple of other things. Now, not to demystify two things, but in all sincerity, when they did a study of Blacks, African Americans here and Blacks in the African continent, they are truly different people, I swear, even if they are Blacks, they are. But again, the Blacks who are here, and I'll tell you this, and that's where the anthropology comes in. If you all know, and I say this all the time, life began in Africa, period. And those who are here now, who are the Caucasians, left Africa over 40, 50,000 years ago. So over 50,000 years, they've had the time to adapt to the temperate region. And those who you see are the descendants of those who survived. There's M gene and there's PQ3 gene and all that, which you can trace out of Africa, that resulted in all the Caucasians, the Indians, and the Chinese. Now, those of us who are here, we're just coming. The maximum we've been here is over 500 years when they forcibly took us out of Africa. But that's another story. And that's why we must begin to understand, why are the things different from who we are, and why is it that, even despite the fact that here in the United States, the people who live here, the Blacks fare worse than anybody else. But then guess what? There are people who live here before we came. We don't see those numbers like them. A few of them, some statistics still show in those rates, meaning Native Americans, still not like bad as it is in our people. So that's the anthropological aspect of it. Outside of the healthcare disparities that come out, meaning access to healthcare, access to doctors, access to medications, access to the ideal care, access to food, and all that. Now, let me go down to the pathophysiology a little bit so that you know why high blood pressure is far much in us, especially here in the US, as compared to where it formed the basis of the problems that we have. Go back home, because that's where it is. If you go back to Africa, we live in what? In the tropical area, correct? And in the tropics, we were predominantly farmers. We were outside. We farmed. And when you farm, you're out in the sun. And when you're out in the sun, what do? You lose fluid. You lose water by perspiration, sweating, and all that. Now, what did nature do, or how God did it? God made it in such a way that you retain salt. When you retain salt, your kidney, which is ideally filters salt, you retain salt. As you retain salt, so that you don't pass out too much water. And if you don't pass out too much water, guess what? You stay rehydrated. Now, if you stay rehydrated, you will be able to sustain and work in the farm and longer from sunset to sunrise to dusk. Now, otherwise, those who don't pass out. Now, that's what we did back home, and that's how our physiology took place. Now, take that person who is in Africa doing that on a daily basis, whose physiology he inherited from his great-great-great-grandparents, and bring him here to America, where there's no sun. He's not out in the street walking. What is still happening to that individual? He's still retaining salt. That person is still retaining salt. And that's why the anthropology and the dynamics of traveling still comes. So when we say high blood pressure is high in our people, yes, there are reasons for it. So when they came here, or when we came here, our physiology still retain salt. And that's why when they told us that the best thing for us to do is to do what? Is to use diuretics. Because when you take the diuretics, you're keeping away those salt materials and keep them so that you would, at the same time, lose some of those salt. That's why the initial function. Other than the genetic components where they describe, I don't want to go into details, but then they forget that those are the same thing that making us retain salt. So when we come here, we're going to still continue to retain salt compared to where we were back home in Africa. Now, fast forward. The statistics here in this, I'll give you global statistics from WHO and what do you call this university? Imperial College of London. They did a study way back in the 1990s and compared it and pushed it up to, I think, the year 2012, actually, where they found out that from the 1970s to 2012, the number of people across the globe with hypertension was about 670, but today is 1.2 billion people living with hypertension. And in America, it's about 47% of individuals who live in this country have high blood pressure. And if you look around the world, majority of people who have high blood pressure don't even know they have high blood pressure. And that's why they call it what? The silent killer. Because you go around with it and you don't even know what's happening. So, and out of that number, of course, men have higher, percentage. And if you break it down to race, that's like he said, it's higher in Blacks, Hispanics, Native Americans, and then the Caucasians eventually. Now, the number of people who have high blood pressure, for what I described, that are controlled, because I'm in the space now, I'm in the field, and I see this, and it's so bewildering to me, where we measure statistics, indices, to know that only 24% of individuals who have high blood pressure are actually controlled. 24%. With a high blood pressure of 140/90, 24%. Now, if you look around the world, that same number is almost about the same as well. And from country to country to country, some countries have high blood pressure compared to others. But when you come to the US, that's the number we begin to see. Again, is that where disparity comes in? Yeah, that's where disparity comes in. And that's where the outcomes of those uncontrolled high blood pressure is so much more. Head, stroke, eye, retinopathy, blindness, heart attacks, kidney failure, and then even peripheral vascular disease. So on top of that, add the social stressor of post-whatever syndrome you want to call it, post-slavery syndrome, social effect and all that, including tobacco and alcohol drinking and obesity. Add that. Then on top of that, add the biggest finality of it, which is diabetes. All of those make everything really, really bad. And that's why when you look at this country, in this country today, Blacks constitute about 13.5%, but 34.6% of us are on dialysis. That's a crazy number. And that's why when he said, if you look at the dialysis center, predominantly of people are Black, it's a fact. And that's why for those of you who've seen their kidney function look recently, when you look at your results, go look at your results, you find out that right now they split the kidney function, which is GFR, separated from Blacks and non-Blacks. So if you look and you identify as Black, then your kidney function is separate from other people, which is a fact. Now, one of the social dynamics that came about that, some people were like, oh, why are they separating? It's racial, discrimination. Why are they separating the kidney function of Blacks versus non-Blacks? And some people were making a big fuss out of it. But smart people came to realize that, you know what? Our kidney function and their kidney function is totally different. Should they stop that? Is that some form of racial discrepancy? No, I tell you, no, it's not. You know why? Because our GFR is so much faster than anybody else. And that's why if you look, your number is always bigger and better than the white person. But guess what? When the kidney damage starts, it's like you on the top of a hill, you roll a ball or something down. It drops down so much faster than other races. And that's why we have to pay attention to that. So when we talk about the medication that we're using, We no longer we do the water pills anymore. No, because the very early signs of kidney of damage, when I said eye, kidney, and all that, to the body, especially the kidney, as we end up on dialysis, is microalbumin. And that's what technology, because I mean, when I was in medical school, we didn't have nothing like microalbumin, because we used to say protein. But by the time the protein gets up to a certain level, the microalbumin level is in the thousands. So the early phase stage, if anybody is here who's
What is
listening,
microalbumin?
albumin is
You know what?
right.
Let's bring the conversation down to my level.
Right. So albumin, you see, this is your result. And if you ask your kidney, your doctor, please tell me those small protein. It's a form of protein. So
Thank you. The
if
small
yeah,
protein.
it's a
Thank you.
small protein. So if you have protein and the protein weight is about 50 grams, and that 50 grams passes through the kidney filter. Now, it may be harder for 50 pounds pound, I'll use the word now, that's an analogy, 50 gram protein to pass through the filter. Now, but because the kidney is still intact, it will not pass through. If the kidney is being damaged, guess what? That space of filter begins to expand. So that 50 pounds will not be able to pass through, because the hole has now extended to 80 centimeters, so 50 pounds, and that's when you begin to see what they call protein in the urine. But guess what? We got smarter enough to realize there are small micro, that's what they call it, albumin, that is your body produced by the liver, that are so small, that are small as 25, 20. Those are the ones that passes through the kidney when there's damage already. So there's an early stage that you see. So when you go see your doctor, please ask for everybody here as a check. Go ask, because the early signs of kidney damage. Go ask. Please check me, see what my microalbumin. Am I spilling protein in the urine already? If you are,
You are muted.
medications that will help protect that. Another one is the eye. And that's why every time you go for eye check, because that eye check tells you if the high blood pressure is beginning to affect the eye. Those are early stages. You know why? Because there's vessels, all these vessels that are affected very early in the body, in the eye, in the kidney, even in the heart, the corona, they are very tiny vessels. So they damage early, faster than anything else. So those are micro, arteries. So once those arteries begin to damage, you see them, and the early ones in the eye. So above everything else, please get your annual well check every year, at least once every year. When you go there, before you go, get ready. It's like going to the church. When you go, get ready. Clean up well, put on your best clothes to go see your doctor, but write down everything you want. Write it down, because once you're sitting down there, you'll be so overwhelmed. By the time they take your blood pressure or keep you waiting for 30, 40 minutes, you're so disoriented. You go through the doctor, you pass out, you forget. Write everything down. So once you see the doctor, look, it's your one-on-one moment to shine. And how do you shine? You shine best when you come with evidence. And the evidence is what you've written down to discuss with your doctor. So that's my take up today. And I hope that is a help. Wow. Thank you and God bless.
Wow. Take home, check your blood pressure, do your annual physical, right? Dr. Ezeugwu, Dr. Aluya, if you don't check, you don't know. Check your blood pressure. That's where it starts. So thank you so much for that contribution. Dr. I'm so glad, Dr. Craig, that you have your hand raised, because all these things you wrote to me, put it together so I don't have to read them. Thank you. The floor is yours.
Greetings, everybody. And also congratulations to those who entered into new positions at NAPAC. So wonderful. Dr. Aluya, you are absolutely correct. There are a couple of things, though, I want to add to. Number one, I know you didn't touch upon it, but we are all, those of us who are second and third generation Black Americans, are all descendants of those who survived the Middle Passage, all descendants of them. And they survived because of their body's ability to hold water. They did not dehydrate. That was a saving grace. When we landed here, we were fed items which were significantly salted because there wasn't any freezers or refrigeration there. So we were fed foods highly salted. And that saving grace became a sword to us. So our pressures went sky high at that point. Yes, our blood pressure is normally higher than those of a white race. In fact, the way it is calibrated, they use a bell curve. All of those numbers which fall in the center of the bell curve represent a norm. We are out of that norm, absolutely. You mentioned dialysis. Dialysis is another form, to my thinking, because I've dealt with it for many years, another way of ball and chain. They would just rather keep people dialyzed because it represents a significant amount of money to be made. The GMP for dialysis is over $55 billion a year. And they'll keep making money because we keep getting sick and we don't understand the issue. Nutritionally, it has been documented, it needs to be read, needs to be followed, that our diet, nutritional diet, and we'll say all of us per se, lacks the understanding that there is an item which is so detrimental to us in terms of control. It is the high fructose corn syrup. It suppresses satiety. It's actually suppresses satiety. So we keep eating. And the obesity, which they claim because we're not being active, which is true, but the obesity is coming from the fact that there is an item in most of our foods which is aiding that problem per se. High blood pressure is the number one reason why Black men go into a kidney failure, the number one at this point. Second, followed by diabetes, of course. But the issue of diabetes is extraordinary, and it has a nutritional basis. We need to spread the word about what we are putting in our mouths. And yes, medication is absolutely important, but to casually medicate someone with an antihypertensive when we haven't done a complete body workup, I think is poor medicine at this point. So, and unfortunately, that's the norm now. Calcium channels are very effective at this point. You mentioned microalbuminemia. The number 20 years ago, when it hit 300, was an indication that that there was a kidney issue. Now, believe it or not, they've changed that number to 1,000, 1 gram. That's when they activate something. So we need to spread the word. We've got to do something. We've got to spread. We've got to educate, and we got to do it properly. That's my take.
Thank you so much, Dr. Craig. Thank you for, if, people don't know, so a lot of people know Dr. Craig, but he has the background in, nutrition, in
renal care.
Pharmacology. So he's put all of that together now to talk to us. Thank you so very much. I appreciate that input. Dr. Jagbe, you have your hand raised. Kindly unmute, sir. Go ahead.
Hey, thank you so much, Dr. Ezeugwu. How do you really say your name, Dr. Ezeugwu?
Ezeugwu.
You got it right. Ezeugwu.
Yes.
It's Ezeugwu, and I think there's an E before the U, right?
Sir, it's Dr. Ezeugwu. Kindly give us your input, sir.
Thank you, Dr. O. I have to know who I'm talking to properly so I can address him appropriately. Anyway, thank you, Dr. Ezeugwu. The presentation was quite detailed. I know somebody who really wants to learn physiology and biochemistry will appreciate that so much. But I wanted to just kind of bring it down to simple level of the main problem that, whether it is by race or by whatever we want to define it by, the main cause of the hypertension that eventually leads to heart failure has to do with high alert, stage of mind, a state of mind that is always on high alert, which is because if you look around, you find out there's so much anxiety everywhere we turn. There's so much anxiety about everything, whether it is the system not working, whether it is, trying to survive, regardless of what the background is. Everything still leads to the point of high stimulation of sympathetic innervation. So, and that is what creates the flight, fright, or fight state of mind. And that is what happens. When you're driving on the street, you see that all the time. People giving you all kinds of gesture, they cut you off. People are impatient in everywhere, in every sphere that you find human beings. All of this creates the state, the hyper state of sympathetic nerve stimulation. And that is what creates the release of cortisol and everything that actually continues to increase the blood pressure. And once the blood pressure is continuously increased on a daily basis, it's not something that primarily because of what we've been eating, but because what is going on in our autonomic nervous system is constantly destroying our body. And then that's what is going to happen. It's going to affect every system. When we talk about the solar plexus is where the action really is for our survival. And once we are on a very high alert system, it's going to always create high blood pressure. Thank you.
Very much. Thank you, sir. So I just want to say this before I go to the chat, that please, when you go to your doctors, and I'm coming to Auntie Tawa's question, when you go to your doctors and you're diagnosed with high blood pressure, you need medication, please do not say, "It is not my lot in Jesus' name. That is not my deal," or "I don't like to take medication," but you are taking supplements. It's, it's still medication. They use fillers to put these things together. And so it is very important to bring that blood pressure down. And what we have learned again tonight from Dr. Ezeugwu is not just bringing the blood pressure down, but using medications that will protect the organs at the same time is important. So it's okay to take medication to correct things if it's needed. But not taking it is a problem. We've heard from Dr. Aluya, we've heard from Dr. Craig about how it came to be that this disease entity that is so horrible is more common in Black people because of where we came from, how our makeup was. And it is what it is. If then one develops high blood pressure, please, let's treat it. Let's take care of it. It's always better to prevent. Prevention starts from knowing. You get screened and then do the needful. So, Dr. Ezeugwu, back to you. Dr. Ademola Oduyebo said, this presentation, your presentation was an eye-opening presentation, but that can you please can arteriosclerosis be diagnosed with mere physical exam? Then, second question, what are the main causes of arteriosclerosis?
Thanks for the question. That's a loaded question in a different way. But arteriosclerosis is actually the buildup of plaques in the blood vessel. And this actually starts from when you are born, as you eat certain things that the body, just the same way body deposit fat in different parts of your body, it deposits some in the blood vessels. And it can be a gradual process, and some of them can become really very strict and can rupture and cause a heart attack. Many a time when those atherosclerosis are there and solidify and get calcified, we can actually pick them up by certain tests, like what we call calcium scoring. We pick them up and see. But that calcification is a way of the body trying to fix that blood vessel, like a crack in the blood vessel. And the more we see those calcifications, the more you know that you're at more higher risk of that atherosclerosis. Now, can you pick it up by other means? Well, if let's say there's a buildup of atherosclerosis where it's significant enough to affect you, where you're having symptoms when you do certain things, get chest pains here and there are other tests that can be done if it's significant and pick up those things. And of course, checking your cholesterol and looking for the bad cholesterol is also a good way to pick up some of these things and early management of it. So, and there are concerns of that, you see a heart doctor who can help, dig more into it.
Thank you so much. See, one thing one has to understand also is that you cannot go and test everything. There are so many tests we have.
Right.
But, when tests are necessary, when tests are needed, we do them. We have to have reasons where we do testings.
Yes.
Testing your cholesterol is key to that, to atherosclerosis. So if you have high cholesterol, it needs to be treated. And diet needs to be changed.
Exactly.
You need to start eating low-fat, low-cholesterol diet. Because, otherwise the end result is not good. That's, the first set of screening. You don't go, if you go and do a full total body screen, for instance, CT scan, MRI, you're going to find things
that are
totally benign. You don't need to worry about, but then those things, the worry itself can now kill you.
That's right.
And they're not necessary. So, checking your cholesterol is a good place to start there. And our first lady, Lady May, said she has been diagnosed with high blood pressure for about 10 years, and her blood pressure is being managed through medications. She does not have a cardiologist. She's asking if you suggest a person with high blood pressure have regular visits also with a cardiologist. So she has a primary care physician managing her blood pressure. She's asking if she should add on a cardiologist to monitor her also.
Yeah, so my answer to that, and I'm glad that you're on proper management and you're being followed and stuff like that. My answer to that is be reasonable. So even if you see a cardiologist once a year or something, at least get a baseline screen as to what stage and where things are. And just remember, if they can make adjustments to put you on the right medicines to protect those organs, then it doesn't, all is well. Yeah, I would encourage that, yes.
Then the primary care can then continue the medication.
Yes, exactly.
Everything has been looked at to say that, okay, this is good, you can now go cruise control. Yeah.
And I'll even go a little bit further. Like sometimes we see patients sent to us, and there are certain medicines we know they need to be on that will help protect their organs. But we know that if we start them on it, we are not able to monitor them as frequent as the primary care would, which will be needed to make sure that the medicine is doing very well and managing things. And we reach out to the primary care doctor, or we leave a note with the patient to talk to the primary care doctor, or even to get an endocrinologist involved, especially when you are talking about diabetes and high blood pressure, to try to put all the necessary medications that not only will benefit managing diabetes, but also protect the kidney, protect the heart. That's key medicines, excellent medication that can be used now in doing those things, to put them in place while we do other things to treat other conditions, because remember, it does not matter what the cause is, the damage just keeping to happen if you don't protect those organs.
Thank you. Thank you so much. We have a medical student, at least I don't know how many of them are on the forum, but we have one, Funshaw, who asked, the last vignette question Was the answer A or B? See, she's on it. She wants to know.
You are on it. Yeah. That's what I would tell you. Yes. And the thing is that you need to protect those organs. But you're gonna read in your books, because what you do to protect your patients is different from what the books may do for exam questions.
Exactly.
So you have to begin to understand those differences. But you're absolutely correct in this sense. Yes.
Yeah, just focus on exam and pass the exams now. When
Yeah.
you get into clinicals, you
Right.
understand the difference.
That's right. That's right.
So our sister Rosemary said, thank you very much for the great info. Please, can you talk about the WPW?
Okay. So WPW is actually a different condition. This it has to do with issues with electrical.
Can you define that, please? Because
Yeah.
I'm sure a lot of people don't know what
It's
it
called
is.
Wolff-Parkinson-White syndrome. But this is just it's a combination of name of people that define this electrical problem with the heart, where there is like a pathway. The heart has electrical component and wiring. Sometimes there's an extra wiring that is not supposed to be there that makes conduction from the upper chamber of the heart to the bottom chamber, and can lead to irregular rhythms, fast rhythms, and can actually lead to even death. And so picking that up is very important. But that's what that means. And usually, if it's picked up, then you should be managed to see how the high risk is. If the risk is high in your family, there are things of sudden death in the family. There are ways to treat it nowadays. If the pathway, which is that particular extra track, can also be cauterized and stuff like that. So, but I will leave that there. It's manageable. It's be picked up. Yes.
Thank you. So, Clem Bamikole says, thank you, sir, for the beautiful presentation, which appears a bit clinical for most of us.
Sure.
He said, please, what symptoms should we look out for as one grows old, say about 50 years? It's asking, bring it home. Give us the simple language. What should we look for? And, it's very important. I think this is just a phenomenal question, because high blood pressure is a silent killer. Go ahead.
No, you're absolutely correct about that. And again, my apologies on this topic. The reason why I did it that way is that high blood pressure is one of those topics that people can take it in different ways and argue about this and that. But I wanted to drill down the bottom line to it, which is the damage and mortality that is causing, and how we can, at least, if we prevent that, and you want to take, you want to be eating something, or you want to be eating that to bring your pressure down, I don't care. But protect those organs from the damage of blood pressure, okay? But not to make the excuse that, oh, it was up because I didn't get my money paid this month, or the taxi driver upset me, or this, that. All those things affect you, okay? Now, because it's a silent situation, if you notice that you have that risk, that your pressure is high, talk to your doctor, get more investigation. Remember, not only just, if you just check the urine for albumin creatinine ratio, so that you already have it, protein in the urine, in the kidney, that means already there's end organ damage coming from that. Then you can say, okay, let's check my heart, get my echo, okay? Even if you don't want to, so be proactive in taking steps to prevent those things. And then also talk with your doctor and say, is this medicine protecting my organs, or is it just to bring the pressure down, okay? And also not say to the doctor, I only want to take one medicine. No, they do different things.
Yeah.
They do different things, so you have to protect the organ, then give medicine to bring the pressure down, and then avoid certain foods, do the exercise, get the weight done. All of those things have to be done to make you have a better life and live from 50 to 90 to 100.
Fantastic. Auntie Tawa had a question that I wanted to tag onto this, but she raised her hand, so I'm going to leave that. I'm going to let her ask it together. But before I bring her on, I had Abe said in the chat box that what about olmesartan medoximil? You know, I think when you mentioned valsartan, and you know about the cost of it was probably when he asked that, and you know,
okay,
a lot of people don't even know what ARB is on the forum and all of
Right.
that. So
right.
Yeah.
So again, I mentioned valsartan just because it is the particular medication in that medication called Entresto, the combination. That's the only reason why I mentioned that, but it's just one medication out of the ARBs. So your olmesartan is what's in that category as well. Okay.
fantastic. So Auntie Tower, go ahead, ma'am.
Good evening, everyone. I have two sets of questions, and I think it's going to affect the two speakers. Thank you for a job well done tonight, both of you. The first one I put on the chat was, what question should we ask our primary physician? And I think it was Dr. Aluya that was saying, when you go for your primary, you need to ask questions, you need to do this, you need to do that. What question does he want us to ask?
Okay, is it Dr. Aluya? Dr. Aluya, are you there, sir? Otherwise, I'm going to make Dr.
Yes, I am. Sorry, I'm actually in a place it's a little dark here now.
It's all right.
Yes. So, okay. Getting to see your doctor, first and foremost, like I said, it's a task that you must take very seriously. It begins by one, understanding who you are, understanding yourself as a person. Like I always say, you will come see me as a doctor, 15 minutes if you're a follow-up, 30 minutes the insurance will allow if you're a new patient or if it's an annual well checkup. Especially the annual checkup is when we sit and talk and discuss issues completely. Now, you are with yourself 24/7, so there's nobody who knows you better than you. So you document some of those things that you need to know. And that includes your family history. You begin. If your mom and father are still alive, what disease do they have? Your brothers and sisters, disease do they have? What medical conditions do they have? Because guess what? You share the same gene with them. It's the same gene that you share. So whatever happened to her, to them, most likely will happen to you. So it's important that you begin to look at things like that, especially our people. We don't know our history. We really don't. And we don't share our history either. For some reason, say it's witchcraft or something, you know? But you must begin to know those things. And if you have something, discuss with your family member. Oh, I've now been diagnosed with high blood pressure or kidney disease or even cancer, because you help protect the next person, just like they will help protect you if they share those information with you. So those are early things. Begin with your history. If you have a history of tobacco smoking, then you're fine. Now, when you actually go for that visit, you may have questions that are troubling you. For instance, oh, you have headaches for the last 2 weeks. You write it down. What kind of headache? Where does it have? What often does it come? Is it when you're angry? Is it when you're asleep? Or is it when before you go to sleep, or you wake up with a headache? Or do you have any other thing with it? Do you have a fever? Do you have visual problem with the headache when it comes? Do you have weakness in any part of your body? All of those symptoms that you feel that you have, that is bugging you, you write those things down. Now, if you have questions and you're taking medications and you think you're having cough, you start taking this medication and you notice that cough started a week or 2 weeks or a month after, and this cough is not going, it's nagging in whatever, those are the things you write down. Any side effects or you think you have, you write those things down so that when you go there, you ask. And if, sometimes the adverse reactions or things you feel that you need to ask. For instance, doc, what's my weight? What's my BMI? Your BMI, which is body mass index, is a measure of your height and your weight. And it's a measure that determines if you're obese, if you're mildly obese, if you're moderately obese, or morbidly obese. Now, the mild one, usually, I mean, obesity less than 25 is none. 26 to about 29 is mild. And then 30 to about 35, 4.9 is moderate. And then you go up to 35 to 40. Now, when you get to 40 and above, that's when you begin to talk about morbid obesity. So look to ask those kids, Doc, do I have morbid obesity? You know? So all of those things determine your possible outcome. Now, in the visit itself, you know, you can also ask what your kidney function looks like, or the test that they need to do. Doc, what test do I need to do for my age? Very important. What screening test do I need to do for my age? For instance, if you're 50, or in fact, even now, 46, you do colonoscopy at 46. We used to say, oh, age 50, you do colonoscopy. But that's a totally different story now. Now they brought it down to 46. What's his name? Chadwick Boseman created that awareness of colon cancer in young black people. Colon cancer in us is very different from colon cancer in others. We get colon cancer earlier than other people. And there's a reason for that as well. The diet, notorious for that. And that's a discussion for another day. What's my kidney function going to look like? You understand? What if you smoke? Do I need to get a CT scan of my lungs to see if I have a cancer? If you're 40, I'm a male, do I need to get a PSA? Back in the days, we used to do digital screening. We don't do that anymore. We actually would do PSA in the blood.
Thank God. Thanks.
That's another story.
I've stuck my hands in the rectal.
The men, you know, and then for colon cancer, like, oh, I don't want nobody sticking anything up my butt. But guess what? If you don't want that, we have a good screening tool now, which is the fecal occult, testing, that you take a sample of the stool, put in the card that they give you, you can mail it to the lab, and they'll screen to see if there's blood in the stool, or they do immunoassay to see if there are cancer cells. Those things are there. Those are questions to ask. If you're a female, you're 40,
Dr.
mammogram.
There's even one. There's one better than that. The Cologuard.
Okay, yeah,
Cologuard
mammogram.
actually
Right.
looks in
Cologuard,
Cologuard.
right? That's the immunoassay, right?
Yeah,
so those things, you understand? If you're a female, pap smear. Have you had a pap smear done? You understand? And then if there's a higher propensity of certain cancers in your family, then guess what? This is time to do some screening. For instance, there's a family member who died of ovarian cancer. You can do those things to screen for ovarian cancer, CA125. You understand? And then you can get an ultrasound done. Those are discussions you have to have with your primary doctor, and a good one will sit with you and know your history and screen you appropriately. Thanks.
Thank you so much. Thank you. Appreciate that.
Thank you.
So, Dr. Ezeugwu.
Yeah.
Two people are asking this question.
Can I ask the rest of my question, please?
I'm sorry. I didn't realize.
Yeah, the other question that I want to ask Dr. Ezeugwu is, you were talking about hypertension, but this one I'm going to ask is hypotension, lower blood pressure. Does that have effect on any organ? I know that I was, but I'm better now. I feel fainted. I feel dizzy. And they check, I was very sportish. And because of that, my blood pressure is always low. Does that affect any organ at all?
Sure. Very low blood pressure does affect organs. They will not perfuse. You know, you don't have enough blood flow to the area, including brain and stuff like that. And usually we try to, bring it up to where the body can function. And of course, removing whatever may be the cause for why the pressure is running low. And of course, if you're on a medication like blood pressure medicine, then adjusting those medications to prevent that, or then evaluating what we'll call autonomic neuropathy or autonomic dysfunction to find if there's other reason that has to do with the nerves why the pressure is low. And then figuring out if the pressure is low only when you stand up or when, trying to figure out what may be the reason. Yeah, but very low blood pressure is not that safe because you can fall as you can pass out, just like you were mentioning. Yes.
And thank you very much. My third question is, does hypertension have any effect on reproductive organs of men and women?
Yeah, so good question. So as we mentioned, we looked at that part where when there is damage happening and the effect on the different tissues. Yeah, you can actually, with high blood pressure, have erectile dysfunction, affecting the nerve, because again, those little blood vessels that feeds those areas, they have problems. And so that's why we say protecting them. And sometimes we run into a situation where by the time a patient gets to us to manage their blood pressure, a lot of damage has already happened, which now require you to use higher medication dose. And then they say it's the medication that is causing them to have those problems, not knowing that those problems are coming actually because of the disease itself. So yeah, you're right. Blood pressure can affect, yeah.
Thank you very much.
Sure.
Thank you very much. So in the chat box, I'm going to combine these two questions. One says, is amlodipine still good to control high blood pressure? And the other is amlodipine damaging to the body organs? Again.
Okay. So that's, again, a very important questions, very, very good questions. Remember, again, the reason why I presented this in a way to allow people to understand that we need certain medicines we know that protect the organs, and then we need other medicine that we know help to bring the pressure down. Okay, amlodipine falls into those what we call calcium channel blockers. Okay, and the thing is that those class will increase what we call those renin, as I mentioned in that presentation. Now, if you combine it with something that protects the organ, it's beautiful. So you have medication that have a combination of amlodipine with something else. This amlodipine with an ARB like Exforge and stuff like that, or Exforge HCTZ. In Exforge HCTZ, which is you have three medicines in one. One is a diuretic, that makes you pee, that amlodipine. Even though they will increase the renal level and stuff like that, the ARB with it blocks that receptor, protect those organs. So then you have the excess angiotensin II, which goes then to be more beneficial. And this is, again, the reason why I brought this discussion. I know it's more detailed, but we have doctors here that manage a lot of primary care patients that can help us begin to abrogate the effect of these things on our people significantly.
Thank you. Thank you so much. Amlodipine is an excellent medication that reduces blood pressure.
Yes.
Just reiterating what Dr. Ezeugwu just said, adding another medication, in that class of ARB to, protect organs is fantastic. So don't shy away from taking two medications, for instance, to control your blood pressure. And if your insurance allows it, that you can get the combination in one drug, which exists, that would be great. But some insurances don't want to pay for that because those are usually more expensive. But you can take the drugs separately. You can take two pills instead of two in one. And insurance will pay for that because those two pills are cheaper to them. So, Dr. A.
Dr. O, if I may add one of the things quickly. When, Sam said so,
you are breaking up.
Everybody. Oh, okay. Can you hear me? I can hear you. Can you hear me?
We can hear you now. Yes.
Right. So, a lot of us are made differently, and your height, your weight, everything is different from everybody else. Of course, unless you have an identical twin, that's a different story. Now there are people who run low, and that's all they are. Irrespective, the pressure just low, and that's how they're genetically coded. I'll tell you why, especially when you're young and you're female and you're slim built. Those things are really important. And I must say that, I'll tell you why I'm saying this. Because sometimes when we have issues and that's why we cannot overemphasize the fact that you at least have to have a doctor checkup once a year, because so that you know these things. I'll give you a typical example that happened one time. I was doing rounds with my residents and the students, and we went in and they presented this case of a 25-year-old who came into the ER and had a fever, couldn't swallow, she was sick, toxic. And so I said, okay, so what happens? They're like, oh, they did a CT scan, they didn't see anything, they did all that and all that. And, but her blood pressure was really low. It was in the 90s, it was 92, 93 and all that. And they gave her like bolus IV fluids, the pressure didn't go up. And they gave her multiple boluses up to like 8 liters of IV fluid. So, and that's the presentation they gave. So when I went upstairs, the patient was upstairs and she was in bed. And she was in bed, the family was surrounding her. And I looked at her, she's a small built woman. And she was, huffing and puffing a little bit. Because when I spoke to her, she was talking in a hurried manner. So I said, okay, madam, do you have children? She said, yes. There's a reason why. I said, how many? And I jokingly said, I said 3, right? And she's like, yeah, how do you know? It was just a random guess. And I said, okay, so you do know you've been in the hospital. So what's your usual blood pressure? Because at that point in time, her pressure was 109 or 108 over 70. So I said, so what's your usual pressure? Because if she had children, so at one point in time, they must have checked her blood pressure. So she's like, oh, my pressure usually runs in the 90s. Okay. So guess what? She went to the ER with a fever and sore throat, couldn't eat, and they said she was dehydrated. Oh, gave her boluses. She was toxic. White count was high. So obviously, what did they do? They gave her, and at the time when I saw her,
she had infection.
Right, her IV fluid was running at 250 cc an hour. So what does that mean? And I said, you guys are going to drown this woman. And they're like, what, doc? The pressure is not up. I said, she's slim built, and her usual blood pressure is in the 90s. So when she came in, her usual blood pressure in the 90s. So when they checked the blood pressure, heart rate, tachycardia, they said, oh, she was toxic, and they needed to give her boluses. So they were drowning her, 8 liters, plus the 250 cc they're running. So I said, you know what, stop this IV fluid right now, and then give her laces. They're like, oh, no, why you? I said, because the fluid that we've given her all in her lungs. Do you hear how she's speaking? She's speaking in a hurried tone because she can't breathe. And I said, for you to learn these things, go get a chest x-ray and you see she had pulmonary edema. And I just left. And then give me what's up, a heads up later we talk. You understand? And truly, she had pulmonary edema. So if we had not sat down to look at that, guess what? That fluid will continue to run overnight. And you know what's going to happen? When she goes to sleep, all that fluid will go to her lungs. Then the next thing they'll call it cold. Oh, it's cold. She can't breathe. What do you think they'll do next? Because she can't breathe, they'll put a tube in her throat. And then she goes to the ICU. So, and along that with fluid, with a tube down her throat, is like a loaf of bread that soaked so much blood. You're not going to go anywhere. That's how this happens. So it's important. Know your blood pressure. It's important.
So thank you so much. Knowing oneself is important. And it's very important to know also that normal blood pressure actually goes down to 90/60. So please remember that number. You know, when we say normal blood pressure should be less than 120/80, remember it is less than. So less than to where? So 90/120 over 60/80. Write that down. So thank you again, Auntie Tawa, for that question that, brought up that conversation. Dr. Ezeugwu, Dr. A says you should please address the role of mental health on the control of blood pressure and heart failure.
Okay, very beautiful question.
Yes.
See, with your mind, you can do a lot of damage. You can do a lot of good. Okay, you can give somebody medication to do something for blood pressure, And under mental stress, the medication may become useless. And this is again where, because stress is everywhere, it can be, and anything can trigger that. And this is again where the importance of medicines that protect the end organs becomes important. They may not drop the blood pressure rapidly as you want, but it's like putting a brake in a rolling stone hitting you, okay? And then you can then over time, the rolling stone will be less. So those mental, you can have a heart attack with normal, we can check you out and blood vessels, everything is good. And under stress, you can have a heart attack and the heart may fail quickly, and we can call it a stress-induced heart failure or stress-induced heart attack. We have a special name for it, but that's not the word for this audience. But those things can happen, and your pressure can rise very rapidly if you're under stress, very quickly. So those things affect. Yes.
So much. So as somebody wrote here to me that please note that we should note our opinion. Our opinion is that the genes loads the gun, but the lifestyle pulls the trigger. The genes load the gun, but the lifestyle pulls the trigger. I agree. Go ahead, please. Please comment on that.
And the medicines we talk about end organ protection are the bulletproof that you wear.
I like that. They're the bulletproof that you wear. Love
That's
it.
Right.
Love
That's
it.
Right. And it's really, really important that we understand pathophysiology, because no matter what the cause is, you cannot stop the cause, but you can at least prevent the effect as much as you can.
Fantastic. Thank you. So I have another one. It says, can you talk a little more about protection and prevention measures? I think we've talked about it. If you can just maybe reiterate briefly.
Okay.
Protection and prevention measures of failure.
All right. So for prevention, get screened, which means checking your pressure, checking for sugar, whatever those things to see if you have risk factors. See your doctor, just the same way we talked about, okay? If you have any of those risks, manage the risk, okay? Managing the risk means that managing of risk continues even when the problem develops. So like things like exercise, weight control, all the proper diet, all this is a continuous process, okay? Now, if that condition has been going on for a while, and there are concerns, there are things you're gonna check to see if organs already have been affected. Like we talk about the, albumin creatinine ratio, which is a basic lab. You can also look at even cholesterol profile to see what your bad cholesterol looks like. And then if you really have, said that, let's say your family blood pressure has an issue, somebody has a heart failure and all that, get into, of course, baseline EKG. Sometimes you can pick up on the EKG if the wall of the heart is actually thickening. So these are basic things. And if you really see that on the EKG, then get an echo or ask the doctor you want to see a heart specialist. Okay, and then ask that at that time when that pressure is still like in 140 over 80, 140, start the proper medication that will protect the organs from those damages. Okay, and if you're doing that, you're gonna find that not only would you not have, you're not gonna have complications, your lifestyle will be even better, your quality of life is better, mortality will be less. There's a lot of benefit from that, and you remain, doing well on a lower dose medication, which are proper medicines, than when you really now fall sick and then you have to have all these other medications coming and the damage is really there and it takes a little bit longer. And this becomes more important for us, like people in the third world countries, where many things, you don't have a lot of things to treat the high-end type of heart situation when the heart has failed. So you really find out that prevention becomes our key thing, and early detection and management is the key. I think you're muted. You're muted.
Thank you
Sorry.
so much for saying that, because that's where I'm coming now. But I want to ask this one question that was asked again, that please, how often should one check one's blood pressure? Daily, weekly, or monthly?
Beautiful, beautiful question. So I will tell you what we do. Like, patient comes in for blood pressure. First, we want blood pressure checked in the morning and the evening, and then in between the days, like that, during the daytime, there's any issue, to just get some good sense of where their destiny is. And in a time, sometimes we'll give them, of course, ambulatory blood pressure monitoring to really pick up the circle of their blood pressure and see where the issue is. Like, as we talked, some people may have it high in the office, some may have it high all the time, some may have it high at home, but picking to know where that pressure is. And then trying to manage it. Like, sometimes we have people on medication twice, and they need to check their pressure before they take that medicine. It gives us a sense of how the pressure is controlled before they get to that medicine, like in the morning. And then they check the medicine before they take the evening medication to tell us how the morning medicine controlled it before the evening medicine. And then we adjust, okay? And then in between, we say, get us some pressure even at your workplace during the daytime, so we can know if there's issue in the work time. Because remember, those flare-ups affects the organs. It's not just an issue of that it's good when I'm at home. No, those flare-up affect the organs. So how frequent you take it really is very important to get it better controlled. Then when you're under cruise control, then you can say, okay, I'll check morning and check evening, check morning and check it, because I know now is cruise control. We give blood pressure machine in the office where when the patient checks it, it comes automatically to us. So there's no way of them manipulating it to help us know where things are.
Fantastic. So I've heard some providers, not physicians, advise patients that if you check your blood pressure and your blood pressure is normal or in certain range, then don't take the medication. Please don't do that. Please do not do that. And I tell my patients all the time, the reason your blood pressure is that level is the medication. So when you don't take it, your blood pressure will go sky high. Honestly, you won't know how long it takes me sometimes to educate patients. And I have to give scenarios, something happens, somebody hits your car or something like that. Your blood pressure goes even way high. There's nothing to, put it at a level because you have not taken your medication. So please don't do that. If you need medication to treat your blood pressure, it is a daily medication. You have to take it every day. There's a reason why the medication is dosed once or twice. There's a reason for each medication. If the medication is once a day, take it once a day. If it's twice a day, twice a day. If it's 3 times a day, take it 3 times a day. There's a reason, like hydralazine. There's a reason why the medication is like that. They have what is called half-lives, full lifespan and all of that. So just trust your doctor and do as they say. So I want to talk I want to mention things that Dr. Ezeugwu is doing in Nigeria. Dr. Ezeugwu, as I told you, assistant professor at the Johns Hopkins Medical University, has his own private practice here, but he has single-handedly, with his wife, behind every great man, there's that wonderfully strong woman. So with his wife, through their nonprofit organization, have established state-of-the-art cardiac clinic in the eastern part of Nigeria, in Enugu. Dr. Ezeugwu, and they're now working on doing the same thing, replicating it in Lagos. They are willing to replicate it anywhere. So if you're on this platform and you are interested in bringing this state-of-the-art clinics to your hometown, to your village, whatever, get with Dr. Ezeugwu. They're ready to do it anywhere. Please tell us more about that and about the insurance system, so that we here in the diaspora can see how with minuscule money, we can actually get insurance for our family members in Nigeria to have primary care, cardiac care, because cardiac is now added to it? I'm speaking too quickly and, I don't want to lose anybody. Please tell us a little bit about it. I think it's very important.
Sure. Thank you so much for that information. Yes, so we opened Heart Disease Prevention and Training Center, and that's the name of it, Heart Disease Prevention and Training Center, with the goal of really a healthier nation, which is a healthier nation for Nigeria and Africa in general as we grow this. The primary thing was really on heart disease issue because, as you guys know, that kills a lot of our people. And we are focusing on prevention, just like we're discussing today. And in the center at Nsukka that was open, we have all types of cardiac evaluation things, ranging from cardiologists seeing you, state-of-the-art lab to, basic testing, cholesterol, urine for protein, the basic things, EKGs, echocardiograms, stress tests, all the way to coronary CTA machine to pick up early coronary disease and really aggressively manage them before people have heart attack and drop in death. We even have established remote monitoring with blood pressure machine, where we actually can monitor their pressure from here. We partner with a company that helps us do that. Of course, the finance in Nigeria is a little bit tricky. So a lot of these are done to help and make sure that the masses have that access to care. It has taken us a while to get through the national health insurance. We're able to get, of course, the primary care thing, which was there before, but with continued argument and back and forth to make people to understand that cardiovascular care is a primary situation that Nigeria needs. And finally, by God's grace, about 3 months or 4 months or so ago, when Buhari signed into law for secondary prevention as part of the National Health Insurance. So our center, the Heart Disease Prevention and Training Center, is accredited for both the primary services and secondary services, which include cardiovascular care. What does that mean? Well, it allows us now to buy into the National Health Insurance and then make that bulk purchasing available to lay people, where we buy them and rifle them out to every person, regardless of, where you are, how poor you are, for 1,000 naira, which is about $1 something, Christian, Muslim, whatever, wherever you are, whatever market where you are. So when you win a lotto insurance, then you have insurance that will cover you for a whole year, and allow people here to even buy insurance to cover village and families, and also designate where they can, they want to help. A typical example, you guys saw some of this video about a village in Enugu State where there's a lot of blindness and a lot of, kwashiorkor and this thing in that location. HDPTs is now going to be providing health insurance to those blind people so they can get care, okay? And the thing is that with, less than $50 or so, you can buy a 1-year insurance for people from Nigeria. And if we capitalize on prevention with them, we will go a long way, because many of them can't afford it when they become really sick, okay? So it becomes an issue of really working with them and making them understand the essence of prevention. Many of them that are in remote patient monitoring, when they're not submitting the data, we see their graph and somebody is reaching out to them. Oh, I forgot. Oh, you can't forget. Okay. But this is, so these are the things we do. And our system is based, have electronic health record, which is cloud-based. The electronic health record is actually built by a Nigerian who is based here. And our remote monitoring system is also cloud-based. And so we are now able to mushroom this in different places and remote places and really manage patients in a way that, would help reduce those catastrophic conditions. I will stop there for now.
Thank you so much. Isn't that amazing? So for our family members, $50 a year per member to cover insurance and cover all of these services. I mean, I saw the video of this village in the eastern part of Nigeria, and I could not rest. I was looking already for interventions, what we need to do, because people they don't have good nutritional food. They don't have vegetables. They're going blind, not even 50 years old. There was a young guy with what looked like elephantiasis. That I'm not even sure what it is. I would just say maybe it is elephantiasis. The leg was just really huge. So Dr. Ezeugwu posted it on one of our physician forums. And I contacted some people already, and they reverted back to him. And he said he will send people from that clinic to the place. And they have done that, evaluated them, and are now going back with not just medical intervention, medical care, but with food. And I felt I needed to talk about this. This is a non-profit organization. So, Dr. Ezeugwu, if you please post your information, if anyone is interested in assisting in this effort, they're going to start the clinic in Lagos. I have many people in Lagos. I'm from Abeokuta, Lagos, Abeokuta axis. We can access that. Already I'm talking to him about having one in Abeokuta. And if you want one in your area, again, like I said, what they put together, and I'm on the board actually, so I know what is going on. I'm on the board of this organization, nonprofit, and so I know exactly what is going on inside there. If you want to assist by contributing, please do so. Want to help your family members, the insurances are purchased upfront to give them the discount. I think when we met with the insurance guy, he said it was 40,000 Naira a year, but with the way Dr. Ezeugwu had structured it, then it will come to like 25,000 a year, something like that. This is Dr. Fawole, you are right. This is indeed revolutionary. And that was why I said, I want to hook him up with, I said it before we started. I won't repeat it on recording, that I'm hooking up with Madam Lara, Madam VP Okunubi, so that we need to let the appropriate people know this. Also, Dr. Ajagbe, our very own Dr. Ajagbe, is going on medical missions to Nigeria in a couple of weeks. Is actually going to different cities. Is doing one with all women. You know how we talk about this, women, awareness, care. Women are really the backbone of the family and needs to be taken care of. And I think its very first one is going to be with the women, and then it's going into the interior villages, cities, to continue to care. And when it goes, they do full primary care intervention as well as dental. So our people, this is Dr. Ajagbe, in case you missed what I said earlier. I compliment you guys, and on behalf of all of us, I say thank you, because this is your time, this is your money, finances, everything that you putting into our people for better health. Thank you so much. We appreciate you.
Yeah, thank you, Dr. Thank you, Dr. Everybody in this forum knows that you give all. Part of even the equipments going to Lagos branch to be started came from your donation to that location. We have a Nigerian that donated a building partner for that particular branch. So we really have beautiful people. We shouldn't let whatever is happening to Nigeria dissuade us from really focusing on what's right for our people. We have to do right. Thank you all. Thank you.
Thank you so much.
So,
thank you all. Thank you so much for, another amazing Medical Mondays with Dr. O. Please, if you want to get in touch with Dr. Ezeugwu and you miss his contact, get with me, I will connect you. If you want to get in touch with Dr. Ajagbe and you don't know his contact information, get with me, I will connect you. Let's work together to build our communities. whatever the government is doing, they're doing. We're praying that things will be better in Nigeria. But what each individual can do goes a long ways. So please, let's get together and just continue to build together, because it's still our people there. Thank you. Thank you. Until we see next week.
Dr. O.
Good night. Yes, sir.
Sorry, I put a comment in the chat, but you didn't.
Thank you, sir.
It has to do with people who are already eating bitter leaf, chewing bitter cola, eating hospital too far, eating all those things. If you are on anti-hypertensive, you must monitor your blood pressure on a regular basis, because those are antihypertensive natural. So your blood pressure will not go below what is supposed to be. So as we try to enjoy natural, sources of nutrition and health, we should also be very cognizant and mindful that some of these things can interact and cause more problems. So let's not overdo any of these things. If you're enjoying hospital too far, reduce amount of bitter leaf you are eating, because they do the same thing. Both of them will reduce your blood pressure and blood sugar. Don't take it if you know you're already taking some big prescription medication, because they will interact.
Thank you so much, sir.
Right, so Doctor, so well, first and foremost, Dr. Ezeugwu, thank you so much for what you do. You are utilizing technology to solving our problems. Like we always say, technology was used to subdue and subjugate and colonize Africa. Technology, again, would be used to liberate Africa. So I thank you for what you do, and it's like they say, your man's job, and God